Good morning, dear friends. Today we are continuing to describe function and pathology of the extrapyramidal nervous system. The motor system, main functions of this system are the regulation of muscle tone, coordination of all our movements. During my previous lecture, we discussed the cerebellum function and pathology. Now, we are discussing the basal ganglia or basal nucleus system, paired subcortical masses or nuclei of gray matter. Mostly, these nuclei are located in the subcortical area and also in the upper part of the brainstem. You can see on this picture the thalamus opticus. Thalamus opticus is the somatosensory subcortical center, and we show this nucleus only for location. Now we are located in the subcortical area, just around thalamus opticus area, where all other basal nuclei are located. You can see on this picture nucleus lenticularis or lentiformis, putamen and two globus pallidus, nucleus caudatus, subthalamic nucleus, substantia nigra. Role of the basal ganglia. The basal ganglia play an important, complex and integral role in the control of movements, selecting and maintaining purposeful motor activity, while suppressing unwanted or useless movement, helping monitor and coordinate slow, sustained contraction related to posture and support, inhibiting muscle tone throughout the body. Proper muscle tone is normally maintained through the balance of excitatory and inhibitory inputs to the neurons, then innervate skeletal muscle. This is the line of cut, and then we turn the picture, and now we can see subcortical area, blue color. This is thalamus, only for coordination, somatosensory center, and striatum and pallidum structures. What are they? This is the picture. This is part of our scheme where we show main central nervous system structures. This is level of thalamus opticus diencephalon, and midbrain level you can see cervical peduncle. So just around thalamus opticus, main basal ganglia are located. Caudate nucleus, on Latin nucleus caudatus, nucleus lentiformis or lenticularis, putamen and two globus pallidus. In midbrain, nucleus subthalamicus or Lewis body, nucleus ruber, substantia nigra. The caudate nucleus and the putamen are usually referred to as the neostriatum or striatum. All other nuclei form pallidum, the oldest motor system in phylogenesis. Another name of the basal ganglia system is striopallidar system. So, if we open this picture again, we can see different colors of putamen and caudate nucleus and globus pallidum. Why? They are different. 4 reasons. The first one, or even 5 reasons. The first one, different structures. The second, different histological structure and different size of cells in striatum and pallidum. Different origin during phylogenesis. Neostriatum, archaeopallidum. Different neuromediators in these two structures and different signs of lesion. Biochemistry or neuropharmacology. It was said these two structures, striatum and pallidum, have different neuromediators. Acetylcholine is main mediator in striatum and dopamine in pallidum. Acetylcholine, greatest concentration in striatum, synthesized by striatum and has excitatory effect. Dopamine, greatest concentration in substantia nigra pallidum, synthesized by substantia nigra and nigral projections in striatum and has inhibiting effect. Normally, in organisms, these two transmitters are in functional balance. Functional concentration of acetylcholine is equal to functional concentration of dopamine. When they are not in balance, we have different syndromes, striatum syndrome and pallidum syndrome. When concentration of acetylcholine is less than functional concentration of dopamine, acetylcholine depletion or dopamine excess results in hypotonic, hyperkinetic syndrome or striatum syndrome, hypotonic, hyperkinetic. In case of pallidum syndrome, acetylcholine excess or dopamine depletion results in the hypertonic, vice versa, hypertonic, hypokinetic syndrome or pallidum syndrome. Some words about hypotonic, hyperkinetic syndrome. You see, hypotonicity plus different types of hyperkinesis, there are typical signs of striatum syndrome. What is it, hyperkinesis? Hyperkinesis means violent movement. Patients cannot hold these violent movements. And in case of striatum syndrome, patients have muscles hypotonia plus different types of hyperkinesis. What are they? The first one is chorea, and involuntary, non-repetitive, irregular, jogging movements affecting limbs and axial muscle groups. Swift grimaces and sudden movements of the head and limbs are good examples. Causes of chorea: neurorheumatism, Seidengamm's chorea, Huntington's disease, anti-Parkinsonian drugs using, encephalitis, hyperthyroidism, hypocalcemia, alcohol. This is our movie. Look at his shoulder. This is chorea.
Скажите с памятью.
Some words about different types of chorea. Seidengamm's chorea, or rheumatic chorea, or mild chorea, or chorea mollis. Seidengamm's chorea is one of the major signs of acute rheumatic fever. Seidengamm's chorea occurs between 5 and 15 years of age. More females than males are affected. Mostly girls 9-12 years old. Clinical features. Choreiform movements are not rhythmic and occur sporadically in different muscle groups. For example, a sitting child might suddenly have an arm jerk, upward followed by a leg extension, and then a head nod. The movements occur in such a way that the child is constantly in motion and seems to be twitching everywhere. Treatment of rheumatic fever, rest of body and mind, sedation may be needed if chorea is severe, and prognosis is very, very good. Recovery usually in course in 6 to 10 weeks. Relapses not infrequent, especially in pregnancy. Chorea gravidarum. Now, we can have patients with sudden comes chorea, rheumatic chorea rarely, because we use during recent decades antibiotics for treatment of rheumatic fever with very good results. Not so good in prognosis disease, the Huntington's disease or St. Vitus dens, and autosomal dominant disorder with onset in middle age, 30-50 years, and progression to death within 10-12 years. Parents of either sex can transmit, and penetrance is complete. Symptom complex, chorea plus dementia, maybe plus behavioral disturbance, personality change, affective disorders, and psychosis occur. Treatment, we don't have effective treatment. This is hereditary disease. Chorea may be controlled by phenothiazines, haloperidol sometimes. No effective therapy for the mental deterioration. Prognosis. The disease slowly progresses. Death is usually due to incurrent infection, often in special psychiatric clinics. Incurrent infection due to lack of active movements. Often they are bedridden patients due to mental deterioration.
Ну,
Мустафа
а детей как ваших зовут?
Мустафа Ливара, старшая дочь и дети. Айдар, 10 и
Пройдитесь по комнате.
One more movie, our movie.
Чего боялся? Ну, сумасшедший сделал.
Я слышу, пальцем попадаете в кончик своего носа.
Закрыть глаза?
Да, да. Угу.
Можно какое-то время контролировать? Да, вы можете.
Вы можете заставить себя вот не двигать рукой?
Ну, вот.
Давайте, попытайтесь. Попытайтесь. Теперь я вас прошу пройтись по комнате. Встаньте и идите.
Бывают такие минуты, что вроде все, притихло. Ну, потом опять.
Назад идите.
Когда лежу, она нет.
They were two our patients with Huntington disease. And you see all these hyperkinesis are violent. The next type of hyperkinesis, this is athetosis. Irregular, slowing, sinuous, writing movements involving the distal parts of the limbs. A result from hypoxic neonatal brain damage or lipid storage diseases, sometimes other diseases. This is the picture of athetosis of hand and foot. This is our patient after stroke.
Так,
Look at
вперед.
his fingers.
Затотоз,
Oh.
получается, или атотоз, если опустите руки. Опустите руки. Еще раз я вас попрошу. Так. Вытяните руки перед собой.
Oh,
Держите,
athetosis.
хорошо. Это стоит.
Dystonia. Slow, sustained abnormal movement. Generalized dystonia with abnormal posturing of head, trunk, and limbs. Idiopathic torsion dystonia. Or maybe partial or focal dystonia. Examples: spasmodic torticollis, unilateral deviation of the hand caused by dystonic contraction of the musculus sternocleidomastoideus. There are different positions of head in case of spasmodic torticollis. This is our patient with spasm, sustained spasm of musculus sternocleidomastoideus and special violent position of her neck and head. One more example of focal dystonia: writer's cramp and musician's cramp. Task-specific dystonia, meaning that it only occurs when performing certain tasks. Writer's cramp is a contraction of hand and arm muscles that happens only when a patient is writing. It does not occur in other situations, such as when a patient is typing or eating. Musician's cramp occurs only when a musician plays an instrument, and the type of cramp experienced is specific to the instrument. This is a very interesting example of patient. This is our patient, our picture of patient with neuro AIDS, HIV infection. Typical for this disease is affection of basal ganglia subcortical area. And in this case, you can see dystonia of his feet. Same patient, dystonic position of the left foot. This is our patient with generalized dystonia. Idiopathic torsion dystonia, this is hereditary disease, and sustained permanent position of patient's trunk muscles, all body muscles. Same patient from his back. This is the picture of the kid with torsion dystonia. Also pictures of patients with torsion dystonia. Other examples of focal dystonia: hemifacial spasm, characterized by involuntary contraction of facial muscles, typically occurring only on this side of the face. Maybe hemiblepharospasm, only example of focal dystonia. Example of other type of focal dystonia, oromandibular dystonia. Oromandibular dystonia. I can say that now in these cases effective treatment is only butylotoxin using, but is not long, and we are to repeat injections in spasmodic muscles after 6-9 months, but it's really effective. Balismus, a type of involuntary movement affecting the proximal limb musculature, manifested in jerking, flinging movements of the extremity, caused by a lesion of or near the contralateral subthalamic nucleus. Usually only one side of the body is involved, resulting in hemibalismus. In case of hemibalismus, one limb often suddenly flies about in all directions, out of control. Balismus on the picture. What are other types of hyperkinesis? Myoclonus, stereotypies, tardive dyskinesia, tardive dystonia, tics, Tourette syndrome, tremor, volitional hyperkinesia, and other types of hyperkinesis may be present, not often. All these types of hyperkinesis are rare, but you are to know names of these types of hyperkinesis which we can have in case of striatum syndrome. This is our patient after stroke with different modalities
Поднимайте вверх,
of
вверх поднимайте.
hyperkinesis.
Так, ага. В стороны опускайте. Не ходите, не ходите.
Combination of different types.
Так, положите на коленочки. Пальцем кончик носа показывайте. Давайте. Опустили. Соедините пальчики вот так, противопоставьте друг другу. Вот так делайте. Давайте. Хорошо.
The second part of our lecture about basal ganglia system is pallidum syndrome, hypertonic hypokinetic syndrome, or Parkinsonism. You remember we can have this syndrome in case of dopamine depletion. You have to know 4 main syndromes of Parkinsonism. The first one is rigidity, extrapyramidal muscle hypertonicity, stiffness felt by the examiner when passively moving a limb. There are 2 types of rigidity: plastic or lead pipe rigidity, a steady increase in resistance throughout the full range of movement, affecting flexor and extensor muscles groups equally. Do you remember one more type of muscles hypertonicity? Spasticity. Spasticity patients can have in case of pyramidal system upper motor neuron pathology. Do you remember clinical characteristics of spasticity? When we check the muscle tone, we have clasp knife phenomenon. When we feel resistance only at the beginning of every movement, at not equal distribution of muscles hypertonicity, more evident in arm flexors and in leg extensors. And due to this muscle tone distribution, patients after stroke with hemiparesis have a Wernicke-Mann posture with flexed arm and extended leg. In this case, we have absolutely another type of muscles hypertonicity, rigidity. Rigidity is typical for extrapyramidal hypertonicity, spasticity for pyramidal hypertonicity. In case of rigidity, patients have equal distribution of muscles hypertonicity throughout the full range of movement, affecting flexor and extensor muscle groups equally. The second is a cogwheel rigidity, a ratchet-like increase in resistance when tremor is superimposed upon rigidity, like on the picture. So, I want to compare on this slide different modalities of hypertonicity. You are to distinguish them. In case of spasticity, type of elevated muscle tone produced by lesion of the pyramidal pathway, the resistance of a spastic upper limb to passive movement is usually strong at first, but may then suddenly give way, clasp knife phenomenon. Alternatively, it may increase on continued passive movement. Rigidity is a viscous or voxy resistance to passive movement that can be felt to an equal extent throughout the entire movement. And cogwheel phenomenon, like on the picture. We can see patients' hypokinesia due to muscle spasticity, muscles hypertonicity. There are terms describing hypokinesia and oligokinesia of patients with Parkinsonism. Hypokinesia, loss of voluntary movement. Bradykinesia, slowness of voluntary movement. Oligokinesia, movement number decrease. Acherokinesia, arm swinging amplitude decrease when walk, and extremities are situated close to trunk. Shuffling gait, small rapid steps to keep up with the center of gravity. Flexed bent posture, reduced facial expression like mask-like face, reduced blinking. This is typical appearance, posture, habitus of Parkinsonian patient. Mask-like face, extremities are located close to the trunk. Same patient standing, mask-like face, expressionless face. The third sign of Parkinsonism, this is tremor. Tremor of rest at a rate 4/8 per second. Peel rolling, cause and character, distal in distribution, the thumb moving rhythmically. It occurs at rest, improves when movement, and disappears during sleep. It begins unilaterally in case of Parkinson's disease, in the upper limbs, and eventually spreads to all 4 limbs. This is our patient with initial stage of Parkinsonism, unilateral tremor.
Назад идите.
Typical Parkinsonian
Назад идите,
rolling
назад
tremor.
поворачивайте и идите. Назад идите, ко мне идите.
Pill rolling,
Вы принесли в своей жизни?
unilateral.
Практически таких серьезных никаких, кроме простуды.
А вас не оперировали?
Ну, кесарево сечение, да?
И все, да? А в инфекционных больницах вы никогда не лежали? Скажите, пожалуйста, у родственников, у мамы, у папы?
Also typical
Так, хорошо.
pill rolling tremor, Parkinsonian tremor. And the fourth big group of symptoms, there are postural disturbances. Flexion of limbs and trunk is associated with a failure to make quick postural or writing adjustment to correct imbalance. The patient falls whilst turning or if pushed, propulsion, lateral pulsion and retropulsion we can observe. This is typical appearance of Parkinson's disease. Masked facial expression, special bent stooped posture, rigidity, forward tilt of trunk, reduced arm swinging, flexed elbows and wrists, small steps, shuffling gait, sometimes trembling of lower extremities, slightly flexed hips and knees, typical habitus of this patient. This is very, very good old movie.
If the disease involves both substantia nigra, there is difficulty in correcting posture when suddenly displaced. This man literally falls backwards when he is lightly pushed. In a healthy subject, rapid passive stretching of a muscle is a smooth movement. In the patient, the stretching is interrupted and is called cogwheel. The volitional movements in the patient are definitely slower than those in the healthy subject. When the patient's hand is placed on his leg, a regular tremor develops in his fingers, thumb, and at the wrist. This tremor is likened to pill rolling. As he walks towards us, the steps are short. The gait is somewhat shuffling. The patient turns slowly. And he sits down awkwardly in a lump.
Classification of Parkinsonian syndromes by Jankovic. 80% this is idiopathic primary Parkinsonism or Parkinson's disease. 10% secondary Parkinsonism. Drug-induced, for example, neuroleptics like haloperidol. Vascular, 2%. For example, after stroke. Post-infections. Toxic, for example, carbon monoxide, manganese, Wilson disease, and 10% plus Parkinsonism or Parkinsonism plus. This is the group of hereditary diseases when patients have Parkinsonism plus anything else. For example, progressive supranuclear palsy, Parkinsonism plus oculomotor disorders, corticobasal degeneration, Parkinsonism plus mental disorders, or something else. 10%. Some words about typical Parkinson's disease. Described by James Parkinson in 1817, he published an essay about shaken palsy. In this essay, he described 6 patients with typical Parkinsonian picture, and he was one of these 6. He suffered from this disease, shaken palsy, and after 50 years, famous French neurologist Charcot proposed to name this disease after James Parkinson. So now we say Parkinson's disease. The cause of Parkinson's disease, unfortunately, is unknown. You can see on the picture incidence, prevalence, sex incidence. I want to draw attention, age of onset, 50 years upwards, rarely earlier in age. Clinical pictures, typical Parkinsonian symptoms. But their first symptoms are unilateral. This is typical for Parkinson's disease. Treatment is symptomatic. It does not halt the pathological process, but really can help. It aims at restoring the dopamine and acetylcholine balance. We know we have dopamine deficiency. And so the first method, we try to increase dopamine and give it exogenous dopa. We give levodopa or levodopa plus inhibitor of side effects, or sometimes we can help with dopamine agonists. A lot of side effects and a lot of problems during usage of levodopa exogenously. Other drugs which we use for treatment of Parkinson's disease. And now we use new methods, surgical methods. One of them is deep brain stimulation, DBS, surgical treatment involving the implantation of a medical device called a brain placemaker, which sends electrical impulses to specific parts of the brain. DBS in select brain regions had provided remarkable therapeutic benefits for otherwise treatment, resistant movement, and affective disorders such as chronic pain, Parkinson's disease, tremor, and dystonia. The FDA approved DBS as a treatment of essential tremor in 1997, for Parkinson's disease in 2002, and dystonia in 2003. On the picture, insertion of electrode during surgery using a stereotactic frame. Stereotactic surgery or stereotaxy is a minimally invasive form of surgical intervention which makes use of three-dimensional coordinate system to locate small targets inside the body and to perform on them some actions such as ablation, biopsy, lesion, injection, stimulation, implantation, radiosurgery, etc. DBS stimulator produces electrical impulses that affect the nerve cells around the electrode and should help alleviate tremors or symptoms that are associated with the affected area. There are a few sites in the brain that can be targeted to achieve different results, so each patient must be assessed individually and a site will be chosen based on their needs. Traditionally, the two most common sites are the subthalamic nucleus and the globus pallidus interna, but other sites such as caudal zona incerta and the polyfugal fibers medial to subthalamic nucleus are being evaluated and showing promise. The major complications were rare, include hemorrhage 1-2% and infection up to 3-5%. And one more new method, this is levodopa intestinal infusion system, treatment of advanced levodopa responsive Parkinson's disease with severe motor fluctuations and hyperdyskinesia, when available combinations of Parkinson medicinal products have not given satisfactory results. Levodopa is gel with continuous intestinal administration. For long-term administration, the gel should help administered with a portable pump directly into the duodenum or upper duodenum by a permanent tube via peritoneal endoscopic gastrostomy with an outer transabdominal tube and inner intestinal tube. Alternatively, radiological gastrostomy may be considered if peritoneal endoscopic gastrostomy is not suitable for any reasons. Thank you for your attention.